what's the real story behind the IOP-lowering effects of MIGS? Much research has been done on surgeries like canaloplasty combined with cataract surgery, but can these procedures stand on their own?
So we've known for many years that cataract surgery alone reduces intraocular pressure. And so when MIGS first came about, there was some skepticism that the reduction in intraocular pressure was solely due to the removal of the cataract surgery. But we know that effect of cataract surgery on intraocular pressure only lasts about 3 years. And so the long-term data is what we really needed to be able to show that it was the actual angle-based procedure that not only reduced intraocular pressure, but maintained it over a long period of time.
Treating glaucoma and cataracts simultaneously holds many advantages, including reducing costs, number of surgeries, and infection risk. Cataract surgery's IOP-lowering effects are well documented, but not everyone has cataracts. The need for data on procedures like standalone canaloplasty is pressing.
It's definitely more common to perform a MIGS procedure in conjunction with cataract surgery. Because of the safety profile, it just makes sense that if we're already in the eye, we might as well try to rejuvenate that natural outflow system or enhance the outflow system so that we can reduce the patient's intraocular pressure and/or medication burden. It's very important that we perform procedures that last a long time in patients, because what we don't want to do is perform a procedure and then a year later have to perform another, and then a year later have to perform another. It really interferes with the patient's trust in what we're doing for them. And so having long-term data now is very important, because we know that when we're taking a patient to the operating room, that it's going to maintain itself beyond 36 months. We published our data in the Journal of Ophthalmology that reviewed our 36-month outcomes following standalone canaloplasty.
In the study, Dr. Gallardo followed a cohort of 72 eyes. Of the 44 eyes that finished the 3-year follow-up, 23 were treated with standalone canaloplasty using iTrack, while 21 eyes were treated with combined iTrack, canaloplasty, and phaco. The patient population was diverse, comprising of about 3/4 Hispanic and 1/4 Caucasian patients. There was also a mix of mild, moderate, and severe glaucoma patients in the cohort.
The majority of our patients in El Paso are Hispanic, and because of that, the data that we collected is in a predominantly Hispanic patient population, but half of those patients had severe disease. Because we'd been performing canaloplasty for 10 years prior, we understood that canaloplasty was very effective in most patients, and because of that, we were able to collect data on a broad array of patients.
At 36 months, both groups demonstrated substantial reductions in mean IOP and medication use. In both groups, mean IOP decreased significantly from baseline, around 20 millimeters of mercury at all follow-up visits, reaching an average of 13 millimeters of mercury at 36 months. This represents a reduction of over 30%. The number of medications decreased from around 3 at baseline to 1.6 at 36 months for the standalone group, and from 2.5 to 1.0 for the combined group, representing a 47% and 60% reduction, respectively.
Most people would tend to think that when you performed canaloplasty in conjunction with cataract surgery, you'd get a higher medication and pressure reduction. But what we found was there was a very similar reduction in the mean IOP, as well as the similar reduction in the mean medication burden reduction.
There was a marked change in the IOP distributions from baseline to 36 months. At the start of the study, a small proportion in either group had IOP levels below 17 millimeters of mercury, and none had levels below 15 millimeters of mercury. Within 12 months, over 90% of patients in both groups achieved IOP levels below 15 millimeters of mercury. This positive trend continued for the remaining 24 months, with over 80% of patients maintaining IOP levels below 15 millimeters of mercury at the 36-month follow-up. Notably, more than 95% of eyes in both groups reached IOP levels below 17 millimeters of mercury after 3 years. This all translates to significant overall percentage reductions in IOP over 36 months. 73.9% of eyes in the standalone group and 61.9% of eyes in the combined group experienced a reduction of equal to or over 30% in IOP. Moreover, over 85% of eyes in both groups achieved at least 20% reduction in IOP at 36 months. These standalone numbers were surprisingly similar to the combined group, even given the IOP-lowering effects of cataract surgery. The number of patients that target IOP after both standalone and combined surgery, around 4/5 of patients, is one of the key findings of the study.
The challenge that we have with glaucoma is that sometimes we have a moving target. We tend to choose a target pressure, and there are some patients that will potentially continue to progress despite achieving that target goal. So we're always having to reevaluate where a patient is in their journey of glaucoma management. But for the most part, we know that the lower the pressure we get, the lower risk they have for progression. And with our long-term data, it's really shown that not only are we reducing intraocular pressure, but we're preserving the visual field, which is the ultimate goal of glaucoma management.
The number of different medications patients are on is the second half of the study's key findings, further bolstering standalone and combined canaloplasty's case. At baseline, only a small percentage of patients in the standalone group were on 2 medications or less. By 36 months, over 60% were on 1 medication or less, with nearly 30% of them being medication-free. Similar results were observed in the combined group, with nearly 80% of patients on 1 or less medications, and over 40% achieving medication-free at 36 months.
Now, with the procedures that we have for standalone and the data that's out there, I think more and more doctors are being driven to perform standalone angle-based procedures. We're in this new interventional glaucoma paradigm shift where we're trying to be more proactive in how we manage patients. And with a procedure like canaloplasty, because it's restorative and non-ablative, I think it's a tool that we're going to be using more and more often as a standalone procedure. What we've been looking at over the past is not only reducing but eliminating a patient's medication burden to enhance quality of life, and canaloplasty fits right into that category of intervening early in a progressive manner. At the same time, not burning any bridges by maintaining the entirety of the outflow system. So we're able to still perform any other procedure that we want in the future.
In the end, the data suggests what MIGS enthusiasts like Dr. Gallardo have long suspected, that canaloplasty plays a role in independently lowering IOP and medication burden simultaneously, and that as a standalone procedure, canaloplasty with iTrack is a viable option in the modern glaucoma treatment paradigm.